I'm going to talk about quality control and trying to get the job done right. And I'm going to give you a couple basic facts and try to keep this at a point that doesn't get too emotional to me. But I care a lot about whether breast exams are done. And if anybody wants to just debate the argument about whether or not breast exams are important, I'll skip that part right now and come back to it in questions if you want to. But breast exams are important. On the other hand, everybody's time is short these days, and breast exams are not going to be done unless you can really keep it simple. So the question is whether or not you can keep it simple and still do it well. So that's my first point. The second background point that people need to understand is that there's no way that anybody can get into the clinic and follow everybody doing everybody's breast exam and figure out whether or not they're doing a good job or not. It's just, think about the practicality of it, it's beyond practical. And therefore, you need some sort of way to know whether or not a person is getting the expected results from doing their breast exams in general. And what I'm going to talk to you about is what's called the call rate. And what this means is that if you examine 100 women, somewhere between 7 and 10 of these women will have something that's unusual. That doesn't mean it's cancer. It just means that women have lots of lumps and bumps. They're not symmetrical. I compare it to the fact that everybody's 2 ears in this room are probably not the same place on their head. Everybody's right foot and left foot are the same size. And if you actually do stereotactic measurement of breast size, 60% of women, their breasts are not the same size. This has all been done. So it's the question of when somebody does breast examinations, they should be noticing a certain number of abnormalities, not because they're cancer, but because if they're not noting those abnormalities, they're not going to note or observe the subtle abnormalities that are cancer. So the metric that we use to evaluate how well breast examination is being done is the call rate. Now, we have looked at the data, and there are some very elaborate methods with very elaborate training systems to teach breast exam, and most of them don't talk about what the doctor thinks. And so we came up with this idea of looking at a different way to get the doctor to think about the breast examination. And embedded in this original study was a prospective study. We were trying to look at whether or not asking more questions about the breast would be more effective than asking fewer questions. We had a longer form that asked more questions and a shorter form that asked, fewer questions. But we wanted the doc not only to look at the breast, but to have kind of a checklist in terms of doing it. I liken this to next time you get on a plane, get there a few minutes early and look out the window at the plane, and you'll realize the co-pilot walks around the plane. The co-pilot does a visual inspection of that plane before you take off, and every once in a while they really find something missing, like missing parts. I've actually been on a plane where that happened. So it's very important that you look very carefully. So what we did is we asked people to do breast exams. We went into a clinic where they had an established practice, an established set of patients, people who've been doing breast exams an average of about 10 years, and we just asked them to add filling out a form to describe their breast exam. And we originally thought we were going to be finding a difference between the long form and the short form, and what we were surprised to find was that the real thing we found is that we, simply by asking them to fill out the questionnaire, doubled the rate at which they identified things on breast examination. And that is exactly what this slide shows. The study mean is the average call rate for the group of patients. It's about 1,500 patients total. And we compare that to going back in the year before and getting a sample of 300 patients. And the call rate goes from just over 4% to just over 8%, which is a statistically significant difference. And what we realized in this is that we had something that's called a Hawthorne effect. Hawthorne was the name of an electric plant that manufactured telephone equipment in the 1930s and 1940s. And they did a study where they were going to say, okay, we're going to improve the care, the manufacturing rate. So they took a bunch of their employees, put them in a separate room, and their productivity went up. And then they started looking at it and figured out that it was simply putting people in the room that made the productivity go up. It wasn't really that they did something different, it's that you were paying attention to them. And so the simple message out of all this is that when docs are asked to pay more attention to what they're doing, they will do a better job. This fits into all of the literature that's out there that shows that when you give docs checklists in the clinic and say, the checklist pops up on the computer and say, did so-and-so get her mammogram, did so-and-so get her flu shot, did so-and-so get, her pap smear and everything like that, you get better compliance. What we've added to that is the fact that if you ask the person to stop and think in a dedicated way about what the results of the exam are, they will actually do a better job.